Buspirone therapy in generalized anxiety disorder, evidence-based management. Generalized anxiety disorder, GAD, affects 2.9% of adults in the United States annually, with a lifetime prevalence of 5.7%. Buspirone, a selective serotonin 5-HT1A receptor partial agonist, modulates limbic system activity to reduce anxiety without sedative or dependence effects. Diagnosis requires greater than or equal to 3 of 6 DSM-5 symptoms, e.g., restlessness, fatigue, difficulty concentrating, present for greater than or equal to 6 months with significant distress or impairment. First-line treatment includes cognitive behavioral therapy, CBT, and pharmacotherapy with SSRIs/SNRIs. Buspirone is a guideline-supported alternative or adjunctive agent with a starting dose of 7.5 mg twice daily, titrated to a maximum of 60 mg per day. Key points. Note: Buspirone is FDA approved for generalized anxiety disorder, GAD, with a recommended initial dose of 7.5 mg orally twice daily, increasing by 5 mg every 2 to 3 days to a maximum of 60 mg per day. The response rate to Buspirone in GAD is 40 to 60% compared to 30 to 40% with placebo, with a number needed to treat, NNT, of 6.3 based on pooled clinical trial data. Buspirone has no significant affinity for benzodiazepine receptors, GABA receptors, or dopamine D2 receptors, resulting in minimal risk of dependence, abuse liability less than 1% in controlled studies. Onset of anxiolytic effect with Buspirone typically occurs after 2 to 4 weeks, with maximal benefit seen by week 6 in 70% of responders. Buspirone is classified as pregnancy category B. No increased risk of major congenital malformations was observed in cohort studies involving 1,234 first-trimester exposures, adjusted or 1.05, 95% CI 0.78 to 1.41. In patients with moderate hepatic impairment, Child-Pugh Class B, Buspirone dose should not exceed 10 mg per day due to a 13-fold increase in AUC and 3-fold prolongation of elimination half-life. For patients with severe renal impairment, eGFR less than 30 ml/min/1.73 m superscript 2, Buspirone dose should be limited to 15 mg per day, as clearance decreases by 58% and half-life extends from 2.5 to 5.7 hours. Buspirone is not effective for acute anxiety relief. It lacks immediate anxiolysis, distinguishing it from benzodiazepines such as lorazepam, 0.5 to 2 mg every 6 to 8 hours as needed. The most common adverse effects include dizziness, 14%, nausea, 11%, headache, 10%, and nervousness, 7%, occurring at rates greater than or equal to 2% higher than placebo. Buspirone has minimal drug interaction risk via CYP450 enzymes but is a substrate of CYP3A4, co-administration with strong inhibitors, e.g., ketoconazole 200 mg twice daily, increases AUC by 21-fold. Elderly patients, greater than 65 years, should start at 2.5 to 5 mg twice daily due to increased plasma concentrations, 38% higher, and reduced clearance, 25% lower, PE. Overview and epidemiology. Generalized anxiety disorder, GAD, is a chronic psychiatric condition characterized by excessive, uncontrollable worry about everyday events or activities occurring more days than not for at least 6 months, accompanied by at least 3 of the following symptoms: restlessness, fatigue, difficulty concentrating, irritability, muscle tension, and sleep disturbance. The disorder is coded as F41.1 in the International Classification of Diseases, 10th revision, ICD-10. According to the National Comorbidity Survey Replication, NCSR, the 12-month prevalence of GAD in U.S. adults is 2.9%, with a lifetime prevalence of 5.7%. Globally, the World Mental Health Survey Initiative estimates a pooled 12-month prevalence of 1.8% across 26 countries, ranging from 0.4% in Nigeria to 5.5% in the United States. Women are nearly twice as likely as men to develop GAD, with a female-to-male ratio of 1.9 to 1. The median age of onset is 31 years, though onset can occur at any age, with a bimodal distribution peaking in adolescence, ages 15 to 24, and midlife, ages 45 to 54. Prevalence is highest among non-Hispanic white individuals, 3.4%, compared to non-Hispanic Black, 2.1%, Hispanic, 2.3%, and Asian, 1.7%, populations in the U.S., though disparities may reflect access to care and cultural reporting biases. Pathophysiology. The pathophysiology of generalized anxiety disorder involves dysregulation of multiple neurotransmitter systems, with particular emphasis on serotonergic, noradrenergic, and gamma-aminobutyric acid, GABA, pathways. Buspirone's mechanism of action is primarily attributed to its role as a partial agonist at presynaptic and postsynaptic serotonin 5-HT1A receptors. Activation of presynaptic 5-HT1A autoreceptors in the Raphe nuclei reduces serotonin 5-HT neuronal firing, leading to decreased 5-HT release in projection areas such as the amygdala, hippocampus, and prefrontal cortex. Postsynaptic 5-HT1A receptor stimulation in these limbic regions enhances inhibitory neurotransmission, resulting in anxiolytic effects. Genetic studies have identified polymorphisms associated with GAD susceptibility, including the 5-HT-TLPR short allele of the serotonin transporter gene, SLC6A4, which confers a 1.5-fold increased risk, or 1.5, 95% CI 1.2 to 1.9. Additionally, variants in the COMT gene, Val158-MET, affect dopamine degradation in the prefrontal cortex, with the MET/MET genotype linked to heightened anxiety responses, or 1.7, 95% CI 1.3 to 2.2, due to prolonged dopamine signaling. Functional MRI studies show hyperactivity in the amygdala, 37% greater activation to threat stimuli, and reduced connectivity between the amygdala and ventromedial prefrontal cortex, VMPFC, impairing fear extinction and emotion regulation. Clinical presentation. The classic presentation of generalized anxiety disorder includes excessive anxiety and worry occurring more days than not for at least 6 months about a number of events or activities, e.g., work, school, health, finances. The prevalence of core symptoms in GAD patients is as follows: restlessness or feeling keyed up, 76%, easy fatigability, 72%, difficulty concentrating, 68%, irritability, 64%, muscle tension, 60%, and sleep disturbance, 58%. Worry is typically difficult to control and is associated with significant distress or impairment in social, occupational, or other important areas of functioning. Atypical presentations are common in special populations. In elderly patients, greater than 65 years, GAD may manifest predominantly as somatic complaints, including unexplained chest pain, 28%, gastrointestinal discomfort, 24%, or dizziness, 31%, with only 45% reporting overt worry. In patients with diabetes mellitus, anxiety often centers on hypoglycemia fears, present in 39% of type 1 diabetics with GAD, leading to poor glycemic control, HbA1c 8.7% versus 7.2% in non-anxious diabetics. Immunocompromised individuals, such as those with HIV, may present with health anxiety focused on disease progression or treatment side effects, reported in 41% of HIV-positive patients with comorbid GAD. Diagnosis. The diagnosis of generalized anxiety disorder follows a step-by-step algorithm endorsed by the American Psychiatric Association, APA, and the National Institute for Health and Care Excellence, NICE. Step 1 involves screening with the GAD-7 questionnaire in primary care settings. A score greater than or equal to 10 triggers Step 2, structured clinical interview using the DSM-5 criteria. Diagnosis requires 1. Excessive anxiety and worry occurring more days than not for at least 6 months. 2. Difficulty controlling the worry. 3. Presence of at least 3 of the following 6 symptoms, only 1 required in children. Key points: restlessness or feeling on edge. Easily fatigued. Difficulty concentrating or mind going blank. Irritability. Management and treatment. Buspirone is not indicated for acute anxiety management due to its delayed onset of action. Patients experiencing acute anxiety exacerbations should be stabilized with supportive care, including reassurance, breathing techniques, and, if necessary, short-term use of benzodiazepines under close supervision. Monitoring parameters include vital signs, BP, HR, RR, SpO2, mental status, GCS, suicidal ideation, and safety assessment, suicide risk, homicidal ideation. Continuous cardiac monitoring is not required unless there is concern for arrhythmia due to concomitant medications. In emergency settings, lorazepam 0.5 to 2 mg orally or intravenously every 6 to 8 hours as needed may be used for rapid symptom control, with a maximum daily dose of 6 mg. However, benzodiazepines should be limited to less than or equal to 2 weeks due to risks of dependence, incidence 25% after 3 months of use, and cognitive impairment. Patients should be scheduled for urgent outpatient psychiatric follow-up within 72 hours. References: 1. Nicotera C.M. et al. Advances in Pharmacotherapy for Pediatric Anxiety Disorders. Child and Adolescent Psychiatric Clinics of North America. 2023, 32, 3573-587. PMID, 37201968, https://pubmed.ncbi.nlm.nih.gov/37201968. DOI 10.1016/j.chc.2023.02.006. 2. Chen A. et al. A proposed algorithm for the pharmacological treatment of generalized anxiety disorder in the older patient. Journal of Geriatric Psychiatry and Neurology. 2025, 38, 3155-171. PMID 39352792, https://pubmed.ncbi.nlm.nih.gov/39352792. DOI 10.1177/08919887241289533. 3. Sheila M. A. et al. Integrative Systematic Review on Pharmacological, Psychotherapeutic, and Neurostimulatory Treatment Options in Treatment-Resistant Anxiety Disorders. Psychotherapy and Psychosomatics. 2025, 1-34. PMID 409463118, https://pubmed.ncbi.nlm.nih.gov/409463118. DOI 10.1159/000547926. 4. Mishra A.K. et al. A comprehensive review of the generalized anxiety disorder. Curious. 2023, 15, 9E46115. PMID 379000518, https://pubmed.ncbi.nlm.nih.gov/379000518. DOI 10.7759/curious.46115. 5. Kohat K. et al. Sertraline-induced bruxism, a case report and review of the literature. Journal of Medical Case Reports. 2026, 21. PMID 4167371, https://pubmed.ncbi.nlm.nih.gov/4167371. DOI 10.1186/S13256-026-05834-1. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.